Hello everyone, in this video I'm going to talk about laser peripheral iridoplasty LPI or gonioplasty. I was to make a video on laser iridotomy first, but as I have seen it many times and I have read it many times and I have read it few times iridoplasty and I have never seen iridoplasty. So in order to understand it deeply and in a better way, also I would like to do it in my coming future on my own, so I should know it in detail and I feel like sharing my knowledge with you. I have read about it and I have seen videos on it recently, so I have collected my favorite videos and I'll share those videos. After this video I'm gonna add those my favorite videos on iridoplasty at the end of this video. So first I'm gonna read, and I don't need to explain because the rest videos have done that part, because unnecessarily it will lengthen the videos and it will keep on repeating the same things again and again. So better I'll just read it in a moderate speed, and then you can watch the videos, my favorite videos, and these are really good. Some are from YouTube and some are from gonioscopy.org site. So iridoplasty, it's a procedure to deepen the angle of antechamber by placement of CW argon laser bones in the peripheral iris to stretch tissue between angle and site of bone. So peripheral iridoplasty, it is an iridoplasty means to change the shape and size of the iris. Also it helps when it's a peripheral iris, it helps in deepening the antechamber angle in the periphery, and helps in plateau iris syndrome. So what is plateau iris configuration syndrome and secondary or pseudoplatis iris? That video I'll make tomorrow. First I'll read from Shields, then Irwin's, then Jacobi, and add some videos and pictures on plateau iris syndrome. So you will understand this iridoplasty in a better way. This is my view on it. So what are the indications of iridoplasty? Medically uncontrolled angle closure glaucoma, to facilitate ALT or SLT in shallow antechamber or narrow angle, to open an oppositional closed angle, to facilitate laser gonio-photocoagulation or laser iridotomy. Nanophthalmos, plateau iris syndrome. Contraindications: flat antechamber, extensive corneal edema or opacity, angle closure associated with extensive peripheral anticyanic. It is for the oppositional angle closure, and in case of the failed iridotomies, especially in plateau iris syndrome. And obviously when the corneal edema or opacity is there, we cannot do these procedures. General steps: explain the procedure, signing informed consent. Minus is achieved with 1 drop of pilocarpine nitrate, 2% at 15-minute intervals starting 2 hours prior to laser. Then anti-glaucoma medication: 1 drop brimonidine tartarate 0.15 to 0.2% or apraclonidine 1% 1 hour prior to laser. Tab acetazolamide 250 mg half hour before laser. Anesthesia: 1 drop topical proparacaine hydrochloride 0.5% few minutes prior to laser. Peribulbar injection of lignocaine hydrochloride in nystagmus and uncooperative patient. Comfortable sitting on revolving stool. Steady fixation, apply head strap and adjust fixation target. The patient is asked to look at the direction of aiming laser beam, even if a thin crescent of the beam encroaches upon the limbus and sclera. Insert appropriate laser contact lens. Gonioscopic laser lenses are not suitable for LPI or gonioplasty due to following reasons: accidental damage to the tubercular meshwork TM and scleral spur may occur. The laser strikes the iris tangentially to inflict diffuse burn and less stromal contraction. The laser shots are applied directly to the iris periphery, to the central area of the lens, thus avoiding the gonioscopy mirror. 9. Room illumination darkened or semi-darkened, and 10th point is adjust slit lamp beam. So LPI technique proper. Parameters: energy 200 to 500 milliwatt, exposure time 0.2 to 0.5 second, then spot size is 200 to 500 micrometer. The parameters and number of burns vary considerably. The energy and exposure is increased if contraction fails to occur. They are decreased on release of pigment or bubble formation. Darker irides require less power. Number of laser bonds. Single session schedule 8 to 12 bonds to the iris periphery in each quadrant. In a single session, 180° is usually treated, that is 6 hours. 6 clock hours of the peripheral iris. Then the contraction effect is visible immediately by deepening of the anterior chamber. So we can see the contraction effect as deepening of the anterior chamber immediately. Then deepening will fail to occur in presence of peripheral anterior synecdoche at that site. Obviously we don't do it. The contraindication is peripheral anterior synecdoche for the laser iridoplasty because the effect is not seen because of the synecdoche. So it is effective in case of the appositional angle closure, especially in the plateau iris syndrome or configuration when the laser iridotomy fails. Site of focus. The laser beam is focused directly on the most visible iris periphery through the flat surface of the laser contact lens. Presence of arcus senilis is ignored. Post-laser advised topical steroids for 3 to 5 days, topical anti-glaucoma medication for 7 days, complications, transient IOP rise, corneal burn, pupillary distortion and iris atrophy. Now you can watch the videos on laser iridoplasty and some videos of the plateau iris configuration, how it is and how the iridoplasty helps in that condition. Thank you so much. Tomorrow I'll be talking on the plateau iris syndrome from the Shields, then from Jacobi, then from Irving's and then Jacobi in 3 parts. Thank you so much for listening to me patiently. Bye.
Ladies and gentlemen, I'm Clement Tam from the Chinese University of Hong Kong. In this video, I'll share with you some critical tips and pearls to make argon laser peripheral iridoplasty work. These are my financial disclosures. Laser peripheral iridoplasty is a technique that applies laser contraction burns in the far extreme periphery of the iris, thereby contracting the iris stroma and leading to mechanical opening of the appositionally closed drainage angle. Now, on the left-hand side here, you see an eye with plateau iris syndrome in which there's a very prominent and anteriorly rotated ciliary body, which pushes the peripheral iris towards the inner surface of the cornea and thereby closing the drainage angle. After applying the laser peripheral iridoplasty, you can see an immediate thinning of the iris stroma, widening of the drainage angle, and the appositionally closed angle is once again reopened. Laser iridoplasty is useful in acute primary angle closure, in acute lens-related mechanism of angle closure, also known as acute phacomorphic angle closure. It is also useful as an elective procedure in plateau iris syndrome, in secondary and malignant glaucomas, as well as being used as an adjunct to various forms of trabeculoplasty, as well as goniosynecdolysis. In some text, it is described that you can use pilocarpy to constrict the pupil before applying ALPI, but personally, I do not do that. What I do is I apply a bright light into the contralateral eye. By doing this, I induce a pupillary constriction, thereby allowing me to access the far peripheral free of the iris with laser applications. And immediately after the laser, I can remove the bright light, allow the pupil to go back into a more physiological state, and so I can immediately reassess the drainage angle for any residual appositional angle closure. Furthermore, you can also consider using aproclonidine or brimonidine to prevent IOP spike. But having said that, IOP spike is actually quite rare after ALPI applications. In terms of laser parameters, normally you would need to use relatively large spot size of about 500 to 1000 microns, longer duration of about 0.5 seconds, and for brown iris, generally we start from a very low laser power of about 150 to 250 milliwatts. For lighter blue iris, you may need to start with a higher laser power. One of the most common reasons for ALPI not to work is because it is being applied not peripherally enough. Now, on the left-hand side here, you see a very effective ALPI opening up a drainage angle, whereas on the right-hand side, the laser spot here is applied too centrally, too near to the pupil. And so the iris stromal contraction induced by the ALPI is not being placed at the right position to open up the drainage angle. This is by far the commonest reasons why ALPI sometimes do not work. Also, you should avoid using the semi-punch burn settings described elsewhere, and these include relatively small spot size, shorter laser application duration, and also high laser power, because such settings will result in charring or burning of the iris, resulting in these small burnt marks, which do not cause much iris stromal contraction. And furthermore, in this particular example, the laser is also being applied too far away from the peripheral iris. And so these laser spots are unlikely to exert any effect in opening up at positionally close angles. You have also got to titrate the laser power against what you see at the slit lamp. If there is no iris stromal contraction, you increase the laser power. Whereas if there is bubble formation, iris charring, pigment release, or if you hear a pop sound, then you decrease the laser power. Normally, over 360 degrees of the iris, we have to apply about 20 to 24 spots. We try to avoid large visible radial vessels as far as we can. And also, we should avoid placing too many spots too closely together because that may increase the risk of iris necrosis or iris atrophy. Now, this is a video showing the application of ALPI in an eye with plateau iris syndrome. You can see that there is immediate iris contraction around the spot of laser application. And this, on the one hand, thins the iris stroma and also pulls the iris away from the drainage angle and thereby reopening at a positionally closed drainage angle. I normally perform this under topical anesthesia, and personally, I prefer the use of the Abraham contact lens. So in conclusion, argon laser peripheral iridoplasty is simple and safe. It effectively opens up at positionally closed drainage angles. Of course, it does not replace iridotomy or open up peripheral anterior synechiae. And also, it is very useful in APAC, in acute phacomorphic angle closure, in plateau iris syndrome, in secondary angle closure, as well as being used as an adjunct in various forms of trabeculoplasty, as well as goniosynechiolysis. Thank you very much indeed for your attention and time. If you are interested to read more about primary angle closure glaucoma, we have this textbook entitled Primary Angle Closure Glaucoma, A Logical Approach in Management, edited by Clement Tam from the Chinese University of Hong Kong and co-authored by a constellation of distinguished clinician scientists working in the field of primary angle closure glaucoma. This book is published by Springer and is currently available on the Springer online shop, Amazon.com, as well as many major booksellers.
Shifting gears to iridoplasty, the iridoplasty is designed to pull the iris out of the angle to shrink the ciliary body back in plateau iris syndrome. It can be done with or without a gonioscopy lens, delivering burns into the very far periphery of the iris. These are the opposite of iridotomy. Iridotomy, one wants a very small, fast, high-intensity burn to penetrate the iris. In this, we want slow, low-power fat burns that just cause the iris to shrink but don't penetrate. So in the range of 200 to 500 microns, long duration, 0.2 to 0.5 seconds, relatively low power. I find that I don't do that many iridoplasties. I see some people with plateau iris syndrome, but I see fewer than I guess others do. So the key points here, iridotomy is designed to eliminate pupillary block. One can use an argon and or a YAG laser and has few complications.
This is a video of an argon laser iridoplasty. In our current view, the limbus is at the bottom of the screen and the pupil at the top. When the argon laser spot is applied, we can see contraction of the surrounding iris tissue. Notice the even spacing between the non-contiguous laser applications.
This 76-year-old woman has a history of narrow angles. She's mildly hyperopic and had undergone laser iridotomies. On indentation, you'll notice that when we push, there's a peripheral roll in the far periphery of the iris. This is very characteristic of plateau iris syndrome. Here I am pushing, you can see corneal folds, and you can see a peripheral roll. As I let up on the pressure, the iris comes back forward, the folds go away, and the iris is again flat with a very narrow iridocorneal angle. Again, I'm pushing. Again, you see the far peripheral roll of iris. I find indentation gonioscopy to be tremendously helpful in making the diagnosis of plateau iris syndrome. Again, pushing here, corneal folds are present, and a peripheral roll in the iris. We let up, the iris returns to its normal shape. Here at higher power, again indenting, and we see the peripheral roll, and we also see the corneal folds. This patient is mildly hyperopic, about 1.75 diopters. His angle is slightly narrow, but we see the trabecular meshwork nicely. On indentation, as the iris moves back, the peripheral iris is held forward, presumably by the ciliary processes, giving this classic sine wave or peripheral roll that one sees in plateau iris. Again here, indenting, we can see this fullness in the far periphery. If there was not this plateau configuration, the far peripheral iris would push back just like the remainder of the iris. So the iris drapes over the lens, and then it should come up to the scleral spur, but in this case it drapes over the lens and comes up over this hump in the periphery, giving one the sense that this patient has plateau iris and an anterior ciliary body. Despite a patent laser iridotomy, this young hyperopic patient had narrow angles. We see when we indent a marked peripheral roll in the iris that is characteristic of plateau iris. Again, as I push in here, you see this roll in the far periphery, and as I let up on the pressure, that roll goes away. Here with some added fill light, it makes it even easier to see this far peripheral roll on indentation. This is really the hallmark of plateau iris.